think everybody's here that's going to be here. I think we're good to start. Call the meeting in order. We'll start with the approval of the minutes from our last meeting. Can you get a motion on that?
I'll move the approval of the minutes.
Second.
First and second, all in favor? Aye. Opposed? Motion carries. Next we'll do the medical staff meeting summary with Dr. Brian Anderson.
All right, so I have a couple staff meetings to report on. Just tried to highlight some things that I felt you might be interested in. So our meeting in August was on the 13th, and then in September was on the 10th. At the August 13th meeting, our health coaches gave us a refresher on annual wellness visits for our Medicare patients, as well as HCC coding. So I think I've talked a little bit about annual wellness visits at previous meetings. That's an important part of our ACO. It's Medicare's, one of Medicare's things to try and improve quality and reduce cost. And so our ACO places a high priority on that. And as part of that, we're trying to capture certain codes that best describe how sick our patients are. And if we do a good job of that, if we code appropriately and demonstrate that our patients are medically complex, that actually will perhaps improve our chances of getting payback from Medicare at the end of the year. So that's an ongoing discussion with the medical staff, is doing a better job of coding as to the complexity of our patients' illnesses and getting these annual wellness visits done. So that was part of our meeting on August 13th. As you know, Dr. Hodges is no longer employed at the hospital, and so there's been some shifting of committee assignments. Dr. Devine is taking over the oversight of the Infection Prevention Committee, and Dr. Kelly Anderson is taking responsibility for oversight of anesthesia and surgery. So as the medical staff changes, those committee assignments often change a little bit as well. At our August meeting, we talked a little bit about the starting date of Dr. Natalie Francis. It was earlier this month, so she has started. She's learning the ropes of our health system and getting going, seeing patients. We've continued to interview surgery candidates. We had a couple this past week that we interviewed. They were actually on site. And they were both good candidates, actually, so follow-up is in process for them, and some decisions will have to be made. The one, if he were to come here, wants to utilize the Da Vinci robot to do surgery, which is kind of the way of the future for the general surgeons. So the ones that are younger and just out of training are wanting to use those robots. So Barry will probably talk about that more with you at coming meetings. But both good surgery candidates, I felt like. There's been talks with rheumatologists to provide telehealth services here at the hospital. And those talks were in process at the August meeting, but as of now, I think we have a contract with rheumatologists to do telehealth services here at the hospital, which is something we need. Some of you may be aware, Crawford County Hospital there in Denison is no longer doing OB. Audubon does not do OB. So Carroll and Myrtue here in Harlan are the only two hospitals in this area still doing OB, and so we expect Dr. Kelly Anderson to get busier with OB patients. And Jennifer Brook, nurse practitioner who previously worked at the Irving Clinic, she is now working for Myrtue part-time, and she will be helping Kelly with the women's health services here and some of the increased workload that we anticipate will be happening. So those are the things from the August meeting that I felt were relevant to share with you. As far as our September meeting, Laura, friend as she often does, talked about various quality measures here at the hospital and what's going on as far as that goes. She made us aware that on the CMS Hospital Compare website, Myrtue has received 5 stars. So you may or may not be aware of that, but we're the only hospital in a 50-mile radius, I guess you would say, to receive that recognition. So in general, the quality at our health system continues to be very good. The medical staff, of course, we do our best, but there's a lot of good people that work at this organization that make this possible. So, and I think it does help us as far as recruiting quality people as well, just to have that kind of a rating as far as our quality goes. Recently, the medical staff had an educational on HIPAA compliance. As you know, HIPAA is largely about medical confidentiality, and so the staff has all recently been reminded that we have to be careful to only utilize information that's relevant for us doing our jobs, and not to be snooping around in other records and seeing what else is going on in other parts of the hospital. So this health system has new software to kind of track some of those things and make sure that we are in HIPAA compliance. In our emergency room, we will soon be using a new chemistry analyzer that helps us with deciding how to manage people with chest pain, people potentially having heart attacks. It's called high sensitivity troponin. It's something being used at other hospital facilities, and we're going to start using it here. It makes decisions perhaps easier as far as who to keep in the hospital, who we can discharge home safely, that type of thing. So our lab has been helping us with that, and we'll start utilizing that here the first part of October. We have a new cardiologist working with CHI who's providing services at Myrtue, Dr. Shiva Konami. I met him once, nice guy. He spent some time at Mayo Clinic on their staff. May have trained there as well. He now works for CHI and will be coming to Myrtue to provide services here along with Dr. Alla and some of that staff that's been coming here for a long time. And then we were informed at our September staff meeting that we are currently recruiting for a dietitian. Julie Klein will be retiring at the end of September, which some of you, or all of you, may know. Julie's been a long-time employee here, so we're looking at getting a new dietitian replacement for her. And then the last thing I was going to mention from our September meeting was Jessica Kuykendall provided education on the 340B program. So that's a program that's largely been poorly understood by the medical staff. I think it's a great benefit for our patients. And we need recurrent education on that just so that we're aware of how it can best be utilized to help our patients in the community here. So she gave us a good update on that. So, a little long-winded today. A lot of things to talk about at every staff meeting. So, I gave you some highlights. I can take questions if you have them.
Thank you, Dr. Anderson.
Congratulations on the 5-star rating.
Yes.
Yeah.
That's a big deal.
It is a big deal, yeah. I'd like to say that the medical staff, that's our thing, but it's not. It's the whole health system. We've got a lot of good people working here. So.
Awesome. All right. Next, we have the quality improvement report by Laura.
We had our last system-wide QI meeting last week on September 18th. Cardiac rehab reported 87% of patients demonstrated an improvement after going through cardiac rehab. which is great. We had 14 departments totally report at that meeting. Diagnostic imaging, they looked at rescan rates for imaging and breast cancer screening recall rates. Both of those were well below the national average. The emergency department evaluated ED arrival time of patients to the time the provider sees the patient, and that's an average of 19 minutes. So that's kind of check-in and the triage nurse doing that, and so the average time was 19 minutes. We were at 99 to 100% of transfer communication being done appropriately. Environmental services monitored compliance with hazardous waste regulations, and all staff, their entire staff just recently went through training on that as well. Medical records monitored the completeness of charts from the ER, done within 48 hours following the patient's admission into the ER, and that was well over 90% that documentation is done accurately and completely. Lab evaluated proficiency testing and also reported they recently had a CLIA inspection and it had no deficiencies. So that was really great news from the lab. Med-Surg department monitored falls and pressure ulcers, both of which we had none. And then they're also monitoring post-hospitalization appointments, that those appointments are scheduled prior to the patient being discharged home. And that's going really well too. They're kind of working on improving that process in the areas that can be improved, and working with the health coaches too, and making sure that loop is closed. So that's all I have.
Okay, thanks Laura. Next we have Karen with the Joint Conference Committee, the last meeting updates.
Okay, I'll pass around, these are all the policies and procedures from the last quarter. So our Joint Conference Committee meets once a month very early in the morning, so thanks to James and Jan for coming early to our meeting and putting up with us for that. It's a two-part meeting. The first part is we review policy and procedure manuals, the entire policy and procedure manual for departments all the way throughout the year, but we take a quarter of them and go through those. So our first ones here that we reviewed, the whole policy and procedure manuals, were for anesthesia, behavioral health, diabetes education, dietary, home health, hospice, human resources, and the team member handbook, medical records, med-surg, and nursing administration. And then the second part of the meeting, then we go into a little more depth on policies and procedures that have changed from this meeting to the last meeting. So it'll be about the 3-month time period, which would have been April through June of this year. And you will hear quite a few times in here, so the Department of Inspections and Appeals, who put out our regulations, make sure we're following them, they actually changed a lot of their tags in their regulation manual. So a lot of what you'll see is that we were changing the policy numbers or tags to coincide with that. So if you're seeing this, and there's a lot of listed as that, I'm not going to go over those in detail because basically it's just number changes to coincide.
So that's the edited CAH policy number?
Yes. Yeah. So yeah, for diagnostic imaging, that's a lot of what they had were the changes of those policy numbers. A few changes to the times of their on-site service for the diagnostic imaging physician coverage. And then the other big one was for contrast media injections for their exams. There were some new guidelines for creatinine and GFR. So they're primarily big changes to their policies and procedures. The next whole page and a half or so is environmental services. Curtis is our new manager of EVS. So he basically did a deep dive into his whole policy procedure book. Did a lot of taking things out, combining things. So you'll see a lot of deletions and then combining to other policies. But basically it's their general policies looking at their whole program. So that's why there's a whole page and a half for that one. OB Birthing Center, they do have a new piece of equipment, the JADA system, which is for any hemorrhage control after delivery. So as you can see, they added that as formulated as a new policy, and then they deleted their old hemorrhage control system, which was the Bacri, which is the last one on there. The rest were pretty minor changes, some different screenings, etc., but mostly minor changes made to those policies and procedures. And the last section there was Senior Life Solutions. They have a new electronic medical record, And so they did have to develop a downtime procedure, so if that medical record were to go down, then they have their paper records to fall back on. So those were all of the changes from the last quarter. So unless there's any questions or comments, these all went through the medical staff approved them, it went through the committee, it was all approved through the committee, so I do need a board.
I'll make a motion to approve.
First, we got a second?
I'll second.
First and a second, all in favor?
Aye.
Opposed? Motion carries.
Thank you.
Now we'll go with Janine with the approval of the Personnel Committee report.
The Personnel Committee met previously to go over the credentialing. This is 2 months as well. We had 22 initial appointments, 21 reappointments, 2 additional privilege between reappointment, and 17 voluntary withdrawals. Make a motion to approve these.
I'll second. Go ahead, Jerry.
Jim's got it.
We have a first and a second by Jim, all in favor?
Aye.
Opposed? Same sign, motion carries. We will go to the consideration of approval of the ER renal project cost by Jeff.
I think I'm going to take this part of it, that Jeff can kind of comment on where we're at with the ER move. So back in April of '23, the board approved this project with total costs, construction costs for $7,458,000. We had tried to estimate what we thought the equipment costs would be, and that estimate at that time was $326,000. We did find some things came in over what we had anticipated. Signage was one of them. It was quite a bit over what we had estimated, so an additional $72,725. The in-pro wall covering, that was something we weren't really satisfied when we went and inspected the kind of the final product. So pretty much all of that has been replaced and installed a little bit differently. We did take a third of the cost of that. The construction manager took a third of it, and the architect took a third of it. So that some additional costs that we weren't planning on. And then there were some other miscellaneous equipment. And then we're also estimating some potential change orders of another $30,000. So I would like to get approval from the board for that additional $155,000 in order to close out this ER project.
I'll make a motion to approve.
Second.
So first and a second, all in favor?
Aye.
Opposed?
Can't turn back now, buddy.
Motion carries.
Comments or?
Well, as of right now, we're still planning to have an open house on October 7th and an opening on October 9th. There's, I think I counted 4 different specialties out there working currently right now, and may have been 5, but feverishly working to ensure that everything is looking right. We did a punch list on the exterior yesterday, a few minor things that need to be fixed there. The interior, we were going to try and punch that yesterday, but that got moved to the next Monday just because there's a number of pretty obvious items that need to be completed, and they'll be done by next Monday, so we can walk through, get our punch list, ensure everything's moving forward. So it looks totally different than the last time everybody walked through. It's starting to look pretty sharp.
The curb appeal looks nice.
Yeah.
Can we talk about that in-pro wall covering thing?
Sure.
What is that?
That is for lack of better terms, a plastic wall covering that goes on the walls to prevent the dings and bumps and dings and gouges and everything on there. The installation of the first time we put it on was very wavy. It was not straight. It was in really bad shape.
Because the product was inferior, or what?
The installation was not correct.
Okay.
They used 1.5-inch staples to secure it, and that caused pressure points to, in some places it was much tighter, and others it was loose spots. there's a cap on top that really highlighted how wavy it was. So that's what prompted us to, really change that. We took the installers up to what my staff has done up in the inpatient areas in some of the rooms. Totally different look and feel, and that is what they have mimicked down in the ED now, and it's a tremendous difference. It looks pretty good now.
So the product they priced was of lesser quality?
No, it was identical. It's the same thing we're using on all of our
No, I
installs
mean
here.
initially.
No, initially it's the same thing. It's just the installation was,
Why are we paying part of it then?
we expanded what we wanted to have covered. For example, in the procedure rooms and the trauma rooms, it went up about 48 inches tall, and we decided to go from floor to ceiling. And so it makes cleaning the rooms a lot easier. So we expanded what was going to be covered. Also above the sinks, the backsplash, it was only up about 8-10 inches, and there was only 4 or 5 inches to the bottom of the cabinets above. So we extended that as one solid piece across the whole thing on the work surfaces of each of the exam rooms.
And your equipment cost, Barry, that number, or Jeff, that equipment cost, you feel that that's still good, the 326?
The 326 were a little bit light, but it is accommodated for on
The 17 catches the difference.
Yep.
Exactly.
All right.
Any other questions on that?
Can't wait to see it. Not to use it, to see it.
You will gently remind us, right? Sure. Okay. Or not so gently in my case.
Just a minute. Okay, try it.
So we need approval on that?
It did.
Yeah.
Any had questions?
That's the way you do it.
Good question.
So,
You can't turn it back, it's too late now.
I know.
not sure if you can see that. Do they have that in the packet?
I cannot see that.
I sent it to them separate.
There you go.
I thought it got dropped.
Oh, there we go.
It
Okay,
should be
so,
an additional, there's some, this is additional.
Yeah.
I'll have to scroll back and forth.
so this is the steel work we've been talking about. We're going to bring that to the September board meeting. So we have a contract in place right now. So this would be an amendment to the existing, amendment to the GMP, to the existing contract that we have with Murray. This is really pretty good news. We had budgeted $1,520,000 for steel. It's actually coming in at this $916,000. So those are comparable, apples to apples, comparable numbers. We do have some additional costs that go along with the steel erection. So when you get down to the bottom, the total cost of this package will be a little over $1 million. But again, we had budgeted $1,520,000. So good news again on where we're coming in on some of these bids. All that major, you want to just make a few comments on what we're talking about here?
Sure. So from our perspective, this was a really successful bid for numerous reasons. One, we received 6 steel bids. And what was really cool to see, they were all, the steel alone, just the trade part, you can see the winning contractor was at $726,000. The other highest number at the other end of the spectrum was $775,000. So everybody was within that range, and it came down to $3,000 difference between our lowest two. The great part was I felt highly confident in our 4 that were kind of the closest to it. Really good contractors, we'd be happy with any of them. The one we're advising you to take is the same one that performed all the steel work on the ED. So same fabricator, same installer, but had great bid coverage, really tight numbers. And what's really exciting for Myrtue to see is we're actually at an 8-year low in steel pricing. So looking at $600,000, that alarms us right away, like, whoa, our estimate is way off. Well, one, when we did our initial DD cost, we were anticipating different steel members. So when the design team went through and created the design, they were able to reduce the amount of steel needed, which reduces cost. And then with the market being really competitive, it is softening, and we're at an 8-year low for steel. That translates into really good savings for you all. So a couple other things in our steel number, these allowances, so line item number 5, bariatric lift allowance, handrail allowance, weather allowance, these will be contractual allowances, so we're going to do our best to stay within that budget or below. Anything we don't spend, we'll credit back to you, but we know that these are potential changes, just as we're still manipulating some of the design for the bariatric lift. Handrail is a safety concern. We think we've got the majority of it covered within our bid package. So, but this gets all of our steel. So we've done our site work. This is steel, and then what we're currently working on is we have the rest of the building, so the shell, all of our exterior finishes, our brick, our glazing, our roofing, interior finishes, that's out to bid right now, and we get those numbers on 10/2, and then we'll come back and report hopefully comparable results a month from now.
A couple questions. Did you say the site work is done then? So did we
The site work bid out is complete. There will be, in this final GMP, there will be some site work items, because when we initially went out to bid, we still had a staircase on the south side. We hadn't included the new elevator tower on the north side, so there'll be some small site work adjustments for concrete and site work there. But we need to give, the trade partners didn't have that information when we went to initial bid, but the majority of the site work, 98% of it is all done.
And you see, they've started out there. They've actually removed the concrete for the alleyway that went up by the side. They've removed a lot of, had to regrade the approach pad in front of the ambulance garage. They removed all that concrete, poured it all back now, and the MRI truck is parking on that. So they have started some of the civil work, run some electrical, also had to coordinate a lot with HMU to move gas pipe, power pipes, water. So they've been rerouted around the perimeter of the property instead of up the edge of the existing clinic.
Have we ascertained the soil quality, if it's good? Or if we have that, is that done?
Not yet. We're about 3 weeks out from that point. So the next few weeks, and Tim, feel free, we're looking at water line relocation, sanitary relocation, a lot of the enabling work to allow us to start excavating. But within the next few weeks, we'll start to move dirt. And we think the way that we've strategized this, we might actually be able to avoid a lot of it by how we're doing it. I can get way more technical if you want, but we think we've got a
I just
pretty
don't want to
good...
spend a lot of money on it. That's the reason I'm asking.
Our current approach is intended to minimize that as much as possible.
So then we talked about, like, there's a price that you guys came up with initially on this. So if it's lower than that, how does that work? Like, do we get all the savings then, or does that get shared?
We haven't set the overall GMP price yet.
Oh, okay.
That hasn't been set yet, but
So here's one way to think about it, and feel free to ask questions, but I'll explain this well. I'm going to use a round number of, we think this entire project's 20,000, right? So we bid out the first section, and we came in at 3.5, but we allocated 4. Okay, $500,000 of savings. Same thing happened here. We allocated roughly 2 million, we came in at 1.5, another savings. We're still looking at the overall project as 20 million. That budget hasn't changed. Now we've kind of moved over about $1 million worth of savings, but we don't want to just take that back just yet, because we want to get these final bids in to make sure that the entire project fits within that $20 million budget. Now, once we get through buyout, when we get done doing our bid process, if we look at Amendment 1 for the earthwork, Amendment 2 for the steel, and Amendment 3, and they're at 19 million, then that's our contract. That $1 million it doesn't go to us, it's still yours. So.
I mean, the only chance that it goes over the 19 million then is if there's scope changes. So if there's things that we add to the project that wasn't in the original design.
And that is the construction cost. We still have the equipment that we need to purchase to fill those rooms.
Right. Yep. I just didn't know how that worked. I mean, I knew that there was something in there, and I knew there was some number that you guys get paid all off of, and I didn't know where that gets locked in. Right?
Yep,
There's
so
a number.
our fee is calculated off the cost of work. So
The GMP.
that's right. So our current GMP this is not an exact number, but our current GDP is around 3 million. Our fee is 3%. Is calculated on that current 3 million. Now we're adding another 916,000 of cost of work, and then you can see we're adding in our liability insurance, our fee. And so we'll do the same thing at this next rendition. So it'll still be, when it's all said and done, our fee's still 3% of the
Whatever that
construction
number
cost.
Yeah.
It's just.
I didn't know if it got set at 20 and then the savings got less, you know, like if we shared it, like.
We only charge you for the cost of work, so if it, yeah, the budget's 20, but if we buy it out, we bid it out, and confirm all of our scope, whatever is not in the budget is still your money.
Thank you for that clarification.
Yeah.
So what we would need today is to get approval for another amendment for $1 million, 1,013,551, so we can move forward with the steel work.
So you'll purchase the steel now then and lock that price in?
Yeah, it's that,
Even though we haven't set the GMP?
We haven't set the overall.
So this, if this thing
GDP,
doesn't
we're
happen,
setting
we
it
still
for
leave
this part
on
of the-
steel?
Just for this part of the project.
Okay. Just making
So I
sure.
would move that approval of the purchase of the steel for $1,013,551.
I'll
First,
second that.
second? We got a second? All in favor?
Aye.
Aye. And opposed? Same sign, motion carries. All right. We'll look at some organizational goals for the results of those for 2024 by Barry.
So I'm sure you're familiar with this slide, you've seen this in the past. So this is the updated score, overall score for our organizational goals for the period July 1, 23 to June 30 of 24. Again, we have the 6 different pillars that we look at: community, finance, growth, people, quality, and service. And we have a 5-point scoring scale. We score each of these. We have one goal under each of these pillars. We have, except for people, we have 2 goals under that one. But it's a 5-point scoring scale. And you can see what our overall score is. When you do the math on all of these various goals, and we have them weighted a little bit differently, but when you add it all together, we're coming down to a score of 4.1, and you can see where we're at last year and the previous year, and all the way back to 2020. But just looking at each individual goal, so community, we encourage volunteerism in the community, and we do, we're not evaluating anybody based on that. It's just kind of encouraging that as a public entity and large employer in town. We do like to, make sure our people we're visible in the community. So this last year we had 7,345 documented volunteer hours among our staff. So that's a score of 4, and we weight that at 5% for our overall goal. Finance had a very good year with finances. Our increase in net position, not including IPERS, and this is not final yet until we have our audit, but right now we're going to be at $3,892,000, which is a score of 5, and that's weighted at 15%. Growth, this is an area that I do think is pretty important, and it's really about more of a mindset of always trying to improve. We put this goal out there for our staff and our managers, and again, it's really about continuous improvement, and this is kind of the way we measure that, is the number of new services that we come up with in the last year. This year we had 22, I think our goal is 20, so that's a score of 3, and that's weighted at 15%. And this is kind of a list of those new services for the past year. And these don't have to be new patient services. Again, they could be a service that maybe a non-clinical area is providing to internal customers. For example, Human Resources shows up on here a few places. So we did meet that goal at a level of 3. People, this is our goal related to our employee satisfaction survey. So our overall satisfaction, when we do our satisfaction survey, we look at all those responses, and our goal is to have more than 90% positive responses. This year we're at 92%, so we did meet our goal at a 3 again. And that's weighted at 10%. Then we have another people goal, and that has to do with retention of employees. This year we did a little bit better than last year. We're at 89% retention compared to about 87% last year, so that was a score of 4. And then quality, we look at about 110 different measures, quality measures, on a quarterly basis, and then we accumulate those all at the end of the year. And we're basically comparing ourselves against benchmarks that maybe have been set by Medicare or other rating agencies. And this year we met 82% of those, which was a level 4. And that area is weighted the highest of all of our goals at 25%. And so you're really not going to be able to see these, but the green means that we met the goal, red means that we did not. But there's, this is something that Laura goes over with the medical staff and other areas on a monthly, well, maybe quarterly basis. So that's where we're at, a score of 4.1 for this last year. I skipped one, didn't I? So service. So this is our patient satisfaction surveys that we do. We have several of them throughout the building. And so we're looking at top box score. We want more than 85% of our responses to be top box, which basically means that we got a score of either a 9 or a 10 on the overall satisfaction for that visit. 9 or a 10 on obviously a total score of 10. And we did pretty well with this one this last year with 93% top box. So that was a score of 5. And then for next year, we did look at the goals, spent a bunch of time looking at this, and we did end up leaving these goals pretty much the same, except we did raise our core measure indicator from 70% to 75%. So we want to meet a little bit higher percentage of those core measures meeting our goals. So any questions on that? I would like approval from the board for the 2025 organizational goals. And I guess the other thing I should say is we do have departmental goals. Every department has their own set of goals that are meant to align with these organizational goals. So they do something similar at the department level. And that's kind of taken into consideration when we're doing evaluations, which we'll be starting that process here in October for all staff. So any questions on that?
I'll make a motion to approve the organizational goals for 2025.
I'll second that. First and a second, all in favor?
Aye.
Opposed, same sign, motion carried.
Yeah, Dr. Anderson did a pretty thorough job of going through a lot of what's happening right now at a higher level. The 5-star, he mentioned that, we're the only hospital within 50 miles. But if you just look at the whole state of Iowa, we were the only one of 7 that got that 5-star measure, and there's about 120 hospitals in the state of Iowa, so.
Impressive.
Very good.
Yes.
And I think, these organizational goals certainly play into that. The fact that we set goals at the beginning of the year and measure them and, kind of make people accountable. And, like Dr. Anderson said, it's certainly, there's a lot of it that's about the medical staff, but it's really about everyone in the organization in order to meet those types of, those goals and the 5-star measure as well. But I think that's all that I have for my report.
Okay. We'll go to Christie now for the approval of the depository resolution, and she has some other things she wants to talk about there, so we'll start with the resolution.
Okay, you should have received a resolution naming our banking depositories, which we don't have to do on an annual basis, but we did add a bank, it's First Interstate Bank, which is the financial institution that IHA is using to do this transfer of money between the state and the hospitals for the directed Medicaid program. So there are times when there is funding in there, but when the timing between when the state puts the money in each of our accounts, so every hospital in Iowa that's participating has an account there, and when they distribute it to us. So we need to get it on our depository resolution, and just knowing the timing of it, so could be a couple different quarterly payments, so I set that limit at 2.5 million. None of the others have changed for our local banks here and some of our other financial institutions that we use for the return on investments and use for our finances. So motion to approve that.
I move to approve the depository resolutions for the financial institutions listed.
Second.
I'm going to abstain from that.
And Kate abstains.
Okay. Yep, with those comments, all in favor?
Aye.
Opposed? Same sign, motion carries. Okay, and then Christie with monthly financial statements.
Okay. So just quickly go through the last, we usually lag a little bit behind in June because we try and finish everything up and get it through audit. We have gone through our audits, hoping to finish up just a few things by the end of the week. We were going to try and meet today to talk about the final cost report, but due to everybody's schedule being a little bit busy and just talking about it yesterday, it didn't happen. So that should happen yet this week. Don't foresee, the contractual adjustment for what our settlement is with Medicare and Medicaid is pretty much the only possibility of a change in the financials. The only other change that's been mentioned that we haven't really discussed is our USDA grant. We were awarded that grant for $1 million for the ER project. We filed the paperwork, met the requirements to get that in June, and so we accrued it, recognized it in June, and they're kind of wavering, well, maybe we need to, because we haven't 100% completed the project, recognize some of that this year versus all of it last year. So overall, it's not going to make any difference in the end. So, but just to finish up June, for outpatient visits last year, we were down 1.6%. So just a few there in that. We were up for emergency room visits for a total of 5,695 last year, for a 5% increase. We did 1,503 surgical procedures, which was an 8.5% increase from the previous year. Physician clinic visits, 42,218, down about 2.4%. Behavioral health had 15,900 visits compared to 16,007 the previous year. Our average daily census had decreased from 9.08 to 7.72. The number of births, we did have 80 births last year compared to 91 the previous year. So if we look at bottom line for the month of June, for the 12 months ended for the fiscal year, June 30th, as of unaudited yet, we're at net income from all sources of 5.9 million compared to 4.3 the previous year.
That's a good year.
Yes, that is a good year.
So I handed out July and August, also, where's my July here? Okay, so just quickly through July, another good month. There's our 4-year comparison, which is in your packet. So for the 1 month ended July 31st of 2024, just doing a comparison, we had a really strong month in outpatient visits. We had 5,000 outpatient visits in the month of July, which is 12.1% higher than they were last year. ER visits were up 2.7% to 486. Surgical procedures are up 3.3%. Physician clinic visits, we had 3,641, which is up 16.9%. Behavioral health is up to 1,226, which was 28.8% higher. Average daily census still running a little low there at 6.13 compared to 7.48. We have 10 births in the month of July compared to 5 last year. And bottom line there for the month of July is 631,000 compared to 215 last year. And again, I've included the 4-year comparisons in there. We're kind of out of that COVID's time frame, so we should be pretty consistent. For August then, we had 5,322 outpatient visits, 459. Emergency room visits, surgical procedures were 130, 3,994 RHC visits, 1,026 behavioral health visits. Average daily census was higher in August of 7.59 patients per day. We had 13 births in August, so we are at 23 this year already compared to 12 last year, and I think they have a few more busy months coming up here. So we've seen an increase in this year over last year in most all of our areas of the facility. So that's great news. And again, for August, we saw a $539,000 net income from all sources compared to a loss last year of $73,000. And year to date, we're at $1.2 million almost compared to $142,000. If you look at our financial report on the balance sheet, we are seeing a little bit more of cash and cash equivalents. That's kind of, we're really having to watch where CDs aren't, treasury notes aren't as good as they used to be. CDs are coming down, but we still just have to have timing to pay for our construction projects, anticipating more construction projects. So it's kind of hard to get some shorter term CDs out there too. So, but we're still considering watching that, and a big portion of our non-operating net income there is our investments that we do have in equities and stock is showing a very high market value right now. So that's good news. Any questions on the financial reports? Jeremy will be out in October to present the audit. So that'll all be finalized and out to the finance committee for review and the board approval in October.
At your finance meetings, do you talk about pulling some of those investments back and taking that cash, those appreciated values off of that to fund some of these projects? Have you talked about that at all?
We'll use up our cash reserves first. I mean, we did just talk, Barry and I did just talk a little bit about that this morning, and trying to reach out for some advice from our local brokers.
Might be a good time to do it. I think if the
and
market's super high, we can maybe get some of those gains and use some of that cash back and lessen our expense.
We're still getting a little, really super close to 5% now on some short-term CDs of 6 to 9 months, but it's going to get
Because we have some in mutual funds, though. That's what I was kind of speaking
Yeah,
toward.
we do still have quite a bit in mutual funds and stocks.
Yeah.
I'll move the approval of the July and August, just the two
Yeah, we'll do June when we do the audit.
financial statements.
I'll second that motion.
All right, first and a second, all in favor?
Aye.
Opposed? Same sign, motion carries. Payroll and claims.
Make a motion to approve payroll and claims for both July and August.
First,
I'll second.
second, all in favor?
Aye.
Aye.
Opposed? Same sign, motion carries. Okay. Without anything for the regular meeting, I'll call for motion to go into closed session for Iowa Code 21.51L for Iowa Code. Is there a motion for that?
So moved.
All second.
First and a second, we'll do roll call.
Aye. Terry.
Janine, aye.
Jan,
Jim, aye.
Kate, aye. Okay, Mike, aye. Looks like motion carries to go into closed session.